was nice meeting you, Brad.
Yeah, you too, Joe. See you guys.
See ya. Bye.
Hello.
Hello.
Hi there.
Hi.
Okay, where are we at here?
Can you hear me?
Yes.
Yep.
Fantastic. Hello, Chris.
Hi.
Hello, Brenda.
Hi,
Hello. Is it Mary or Marie?
Mary.
Hi, Mary. Nice to meet you.
You too.
I can see everything.
All right. Great. All right. Who else do we have? Hello, Scott. How are you?
Hey, sir. How are you?
All right. Great.
Hi, Joe. I'm Bruce.
Hi, Bruce. I was just going to say, I didn't see an LJ Watson, but I see a Bruce Watson. So, all right.
It's my wife's computer.
That'll work. That will work totally fine. All right. We've got a couple more that I think are going to show up here. So I'm going to give a couple more minutes before we start. Do you guys have any burning questions before we start or anything? Want to make sure that we get answered, or make sure that if I don't answer it during the session, I'll be waiting afterwards or stay longer afterwards, whatever, to answer any questions that you need. So we'll take as much time as we need. First and foremost, Tracy sent an email today to you guys, kind of confirming everything, and then also sent you hopefully 3 attachments with it. One was the outline that has all the answers into it, so you guys don't have to write anything down. Typically, if we do these in person, I make you write things out or fill in the blanks, I should say, but I didn't want to have you do that today over Zoom. And then there should be a exercise sheet that shows a couple of different exercises, a couple stretches in the doorway, and another shoulder blade retraction exercise for you guys. And then an anatomical shoulder blade view as well too, and some links to some things for you. So some information as far as that goes. So hopefully you received those. We'll refer to those during the session as well too tonight. So if you don't have them handy, don't worry about them. They're there for you and everything else. But if at any point in time, and I'll reiterate that at the end, if you want those sent again, or if you need something else, never hesitate to email me and let me know what you need or what questions you have. And so we'll try to get you the information and get you directed to the right spot. All right.
Thanks, Joe.
All right. And I hope you guys can hear me okay. Is volume okay for everybody?
Yep.
Great. All right. Well,
I want to live in the woods like
Mary.
Mary.
Yeah.
I wish it was like this year round.
Fall is my favorite time, so it's a very beautiful backdrop.
Yeah.
That's for sure. All right. Well, I'm going to be respectful of your time, so I'm going to bring this down here and kind of move us a little bit. So hopefully you guys can see me. Excellent. All right. So as I mentioned to you, let me know if there's any burning questions. You can always just kind of raise your hand during it as well too. If you know Zoom, there's a way to raise your hand in the Zoom, and you can do that and flag it if you want, but there's just gonna be a few of us. It's not gonna be too many, maybe 1 or 2 more people. So I'll be able to see everybody. Just kind of raise your hand and I'll stop and we'll get your question at least asked, and then whether we answer it then or at the end, we'll go from there. So don't hesitate to stop me and everything else like that. So sometimes I'll get going and I might just get in a zone here, and especially on Zoom, it gets a little bit easier too. So I'm going to try to make this interactive for you all, so you can learn and be interactive and not fall asleep, but more importantly, learn some things and answer any questions that you have. So, all right, anything before we start here?
Nope.
Excellent. All right. So for those of you that don't know me, and I know two of these individuals on the call already on the session, but for those that don't know me, my name is Joe King. I'm the owner of Physical Therapy Advantage here in North Aurora. I'm originally from Nebraska. I moved out here to the Chicagoland area 23 plus years ago. But I opened up my clinic about 13 and a half years ago, and it's been a great ride since. Over those 23 years plus, I've basically been in the outpatient orthopedic setting. I've done numerous courses and continuing education in manual therapy and exercise prescription. And a lot of it, basically the second most seen injury that we see in the clinic is basically the shoulder. And so I spent a lot of courses on the shoulder to try to help our clients and try to build up our basically repertoire of tool bag, or biggest tool bag we can get to help our clients as much as we possibly can. So it's not always one size fits all, one method fits all. So we try to get as many tools in that tool bag as we possibly can to help out. And hopefully you'll kind of gather that as we go along and learn some things as well. So that's who I am. The first question I have for you guys, interactive, and you can just raise your hand, is in the last 30 days, who has experienced shoulder pain? Okay. All right, we're unanimous there. Excellent. I can even go into that too, because I had a hard workout last week and I probably overdid it a little bit as well. So, if you don't mind me asking, if anybody wants to volunteer, kind of what their pain levels were and what they were doing or what seems to aggravate their pain.
Reaching back behind me, or putting my jacket on with my right arm first so that I have to get the left arm more contorted to get the sleeve on my arm, or also reaching over just to the side with something in my hand, like the bedspread, trying to flip it and then straining a little further back with that arm.
Okay. How on the average, what is that pain level like, Brenda?
Well, when it hits me,
Yeah, when it hits
8,
Okay.
but it doesn't usually last. Then it just throbs, and maybe 3
Okay.
for a day.
Excellent. Thank you for sharing. Anybody else?
I'm not really, it comes and goes, and I guess it depends on what I've been doing for what period of time, but it's usually it's always my dominant shoulder, and it's more on the top of it with just normal reaching or sometimes pulling, and when it gets to the level of 8 or 9, but then it can be 2. So it varies by the day and what's been happening.
Okay. But it's just always in the front typically though.
Yeah.
Excellent. Thank you for sharing, Chris. Anybody else?
So I've been working from home, probably like a lot of people have, since March. I tried to make my setup as ergonomically correct as possible, but just like in the last month, I really started noticing it was more like in the little collarbone area.
Mhm.
It's not really a pain where I can describe that it's like a sharp or jabbing or any sort of like really severe pain, but it's just some discomfort. And every once in a while, I will feel like a burning, like right there in the little collarbone. So it just feels like I just need to stretch it out more, which I have been trying to do. And I did adjust the level of my desk. So yeah, like I said, I've got my office chair, I've got a monitor, I've got a little, the mouse pad with the resting for the wrist. So
Yes.
I think it's helping a little bit. So that's my issue. I think mainly I probably just need to stretch. And I don't know what the deal is with that little collarbone, but I guess it's all connected.
Yeah, we can go back to the old school, neck bone's connected to the shoulder bone, it goes all the way down. So,
Yeah.
absolutely.
Well, I actually find that I suffered the most at night while I was sleeping. It disrupted my sleep. During the day, I could kind of protect it, and just kind of get by or just go easy on it. But at night, rolling over and that kind of stuff, it was difficult. It was really difficult. And then I'd wake up in the morning and it still hurts, but then I'd kind of get through my day. But it mostly affected me at night while I was sleeping.
Does it matter what side you're sleeping on? Does it hurt both
Oh
sides?
yeah. I mean, so when it's on that, I tend to be a side sleeper. So when I was on that right side, it was really rough. Or rolling over, that hurt. So I mean, I was awakened many times, in the night just because of it.
So if you lie on your left side, Bruce, does it hurt then too, or does it just mostly only hurt when you're lying on your right and then you're rolling?
If I lay on my left side and I can position my arm just right, it's fine. But usually if it falls back a little bit, then it really catches bad, or even coming forward. So it kind of has to be balanced in that right spot. Otherwise, I experience the pain.
We'll try to help that out before you leave.
Okay, great.
Okay, so my pain is more in my shoulder blade, my left shoulder blade. And mine more starts when I wake up and I feel increased kind of tightness or pain the longer I sit or I don't move around. So those are my symptoms.
So does the pain, Scott, then for you, you say you wake up with it?
Right. So when I get out of bed, I'll feel right away if I try to move my left shoulder, I'll feel pain around my shoulder blade and back. And then the more I move or don't have my mind on it, it's not as bad. But then if I'm sitting, it's hard for me to sit for more than 25, 30 minutes without wanting to get up.
So a long car ride would bother it as well.
Mm-hmm.
Okay. All right. Do you do computer?
And mine don't make a lot of sounds, so I'm not sure what is rubbing against what back there, but mine don't make sound.
It's extra snacks. They're called Rice Krispies. So you just can't eat too many of them. So that's the technical term too. All right. So what I'm actually going to have you do is, and you guys can do it in a sitting position, which is totally fine, is we're going to actually first do some neck motion real quickly here. So I want you to, very nice and easy, I want you to look up to the ceiling and then look down to the floor. Good. And then look straight ahead. Do either one of those bother you? Okay, got one. All right. So now I want you to look over your left shoulder as far as you can, and then look over your right shoulder as far as you can. Good. Do either one of those bother your shoulder pain? Okay.
It feels tight. It doesn't hurt. It just feels tight.
Mm-hmm.
And I did do those exercises on the sheet on the doorway, and those felt great for me. So I think I really just need to stretch it out more.
Good. Excellent. All right. So the last neck motion we're going to do, and this is a real tough one to do, is bringing your ear to your shoulder. So bring your right ear to your right shoulder. Don't bring your shoulder up. And then bring your left ear to your left shoulder. And any pain with that or just crunching?
I have pain.
Tightness.
Tightness.
Sore.
Mm-hmm. Mm-hmm.
Okay. All right.
Scott.
So now the next thing we're going to do is we're going to go on to some arm movements. So now just going to take your arms and then out in front of you and then bringing them up overhead as far as you can. Good. Does that cause anybody's pain or reproduce any of your pain level?
Little pull. There's a little like yank.
Same here, like right in this area.
Okay. And then we're
At full extension. Yeah, at full extension. When it's fully extended, that's when I feel it.
Okay.
Up to that point is fine.
Yeah. All right. So we're at the top. So put your arms out directly out the side. We're going to turn your palms up and then bring them up overhead. Good. Does that one bother anybody?
Yeah, I'll fight pain across most of my ligaments, all of it, whatever you want to call all of it.
On the side there, okay. All right. And so the second last thing we're gonna do, if you can see me here, I'm gonna put my hands. So you have your elbows at your side with your hands facing forward, like at a 90 degree. And then you're just gonna rotate your hands out and then back in.
Can't really see what you're doing there.
Okay, I'm gonna
Joe.
pull out here. So hopefully you can see this a little better.
Mhm.
There we go. Out and then back in. And does that bother anybody?
Bothers me.
It does
Okay.
you?
No.
Little bit
I
me,
got
and I
my
got a
neck.
pop.
Wow. All right. Is that like a lollipop, Chris?
Yeah, I wish.
Yeah. All right. So the last one we're going to try to do is with your good arm, your non-painful arm, reaching behind your back here. All right. So you're going to reach behind your back as far as you can with your good arm. All right. And then you relax. And then you, with your bad one, how far can you go?
Oh,
All right.
I can
I
do
see
it, but it
Bruce
just hurts.
said no. I see
yeah,
Brenda scrunching
That one
up.
causes a lot of pain for me.
Okay.
yeah. I can do it, but yeah, it hurts. You can feel the pull.
Okay. All right. Very, very good. All right. So as you're finding out already is that, you know, multiple things happen and multiple movements can bother each individual a little bit differently, but that pain is the biggest thing that we're dealing with right now, is that when the motion is painful and you're having to deal with pain on a daily basis, that can be very energy draining. Okay. It can be really, really tiresome, and you have to deal with it. It's a mental drain, it's a physical drain, and everything else. And dealing with pain on a day-to-day basis can lead to a lot of bad things. So if you don't address it, you have a lot of other ailments or other problems down the line. So we always are a big advocate of addressing those issues sooner rather than later, because we're really good as humans as putting things in the back burner and ignoring them, but realizing our body tells us what we need to be doing and what we need to be addressing. So it's a big thing to think about. Yep. You bet, Bruce.
So Joe, so one of the questions I have is when it starts to hurt, do you just back off, or do you just continue or try to come back into it again slowly? At what point do you stop resting it and start to strengthen it again? Or what point do you, when you feel a little pain, you don't just back off, you just kind of continue with it? You know what I'm saying?
Sure. Those are all great questions. And we'll get to most of them here, but basically I'm going to tell you that the first thing is, at least here in our clinic, we don't believe in the no pain, no gain theory. If you're creating pain, you're creating inflammation, you're creating irritation, and you're going to take steps backwards no matter what. So pushing through something and creating pain while you're doing it is more than likely not the best option. 9.5 times out of 10. There are some very, very rare instances, but only under the supervision of a physician or a therapist or somebody, a medical professional, would you be able to do that. So you always you don't want to create pain. But as you said, do I step back and try it slower and go a little bit easier into it? And we're always big advocates of going to the point of pain and stopping right before that point of pain and then coming back. And as you are gaining strength, as you are loosening things up, as you're improving your mobility, as you're working on your posture, as you're improving your, what we're going to call neuromuscular recruitment, as you are recruiting your muscles better and more appropriately, now I can go farther with less pain. I still feel it, but it's not nearly the same as I was before. Okay. And we work on strengthening in the range of motion that you can do. And then as you're getting stronger, it's like, wow, I can do this now. Okay, now let's see if I can go a little farther. Oh, you know what? Now that's not as bad. Last week or 2 weeks ago when I tried that with this 2-pound weight, I couldn't do it because it hurt. You know what? Just I feel a tinge now. So definitely getting a little bit better. So we take it in steps and progressions. So hope that kind of generally answers your question. We can get a little bit more into it later. All right. So we're going to talk really briefly about the anatomy of the shoulder. And so it's on your sheet there, but basically the shoulder is a ball and socket joint, okay? And the rotator cuff muscle is made up of 4 muscles. It's not the rotary cuff that sometimes people hear, it's a rotator because it works rotation. So it does this motion or that motion. That's what the rotator cuff, it helps externally rotate going out and internally rotate coming in. And so there's 4 muscles, and that's what the picture of the shoulder blade with those muscles on that anatomy piece of paper that you have there, which show you here, is the same kind of model that I have here. You have a picture from, this is the picture of the front, and that's the picture from the back view. And there's the collarbone, Mary, that you're talking about. This is your right shoulder that you're describing, and there's your collarbone right there. All right. So there's 4 different muscles. So the ball of your arm going into the socket there, and you have the rotator cuff muscles. So you have one big one right here, which rotates the arm in. Then you have 3 of them here. You have one on top, which helps elevate the arm. You have one big one right here, which rotates the arm out. And then you have a little guy right there, which helps also rotate the arm out. And there's a 5th guy on here. It's the ugly stepsister right there too. So that's the Terry's major, and it helps with the pulling in. But there's really 4 rotator cuff muscles. And I won't go into the names of them and stuff like that. They're long, they're hard to remember, but there's really 4 rotator cuff muscles. The other muscle you see here on this model and the other model here, you'll see the top part of it. That's your bicep muscle, which is very intricate into the shoulder because, as you can see, the tendon goes all the way up and around that ball. And that ball goes in the socket. All right. And so you guys aren't going to be able to see this great on your sheet of paper, and it's going to be very tough here, but I'm going to pull the tendons of the rotator cuff away, and you can see the socket there. I'm going to try to pull it from the side there. There's really not much socket there. It's pretty flat, actually. So I did this ahead of time. So you can, here's my drawing of that shoulder, basically, right, like that. All right. So you've got the ball going into that socket. This red piece right there, and there's a red piece right there. So on the top and the bottom and the whole, basically around that socket is a cartilage called a labrum. All right. And that is a fibrocartilage. It's basically like rubber, a hard rubber, and that creates a deeper socket. So instead of being a flat ball, now you actually have a deeper socket to hold that ball in. So it's not truly all bone deep socket like your hip. It is a much more shallow socket. So it is the most mobile joint in the body. So that's why it is so important that you are strong surrounding it. It relies so much more on muscles to strengthen and stabilize the shoulder than any other joint in the body, because it is such a mobile joint and such a shallow socket in there. All right. And the labrum helps kind of give it a little bit of stability, but it's not a bony stability. It's kind of rubberized, so it can actually move a little bit. So on your sheet there, like I said, it's going to have 4 muscles. It's a ball and socket. It's the most mobile joint. And then it has multiple areas, as number D says. You have the collarbone, which is your clavicle. It's got your rotator cuff, which is the 4 muscles. It relies on the shoulder blade, or what we call your scapula, which is the bony portion where these muscles are on. It sits on the ribs. It just kind of lies on the ribs. And then the actual ball and socket itself. So all these things have to play nice in the sandbox together, basically, for things to happen. So for you to raise your arm up, it's got to do things like this. So that ball and socket has to dive down and rotate and twist and everything else. And your shoulder blade's got to move on your rib cage, and things have to happen. Muscles fire at certain times with certain intensities. And if those muscles are weak or certain muscles are tight and restricted, something over time is going to happen. Mechanically, something's going to bind up, and there's going to be some friction or some pain or pinching or something. Or you're going to overstrain it when it's in a vulnerable position, and you're going to overstrain it and potentially tear a muscle or strain a muscle and stretch it out too far. So those are things you're concerned about because it's the most mobile joint in the body. There's so much to coordinate. So that's one of the reasons why it's also it's the second most leading injury that we probably see and most people injure over the course of their lifetime.
Joe, I have a question. Is there a way to tell that whether the pain is related to the muscle or the tendon or the bone?
Great question. Yeah. So clinically, we do some testing when we have clients come in and stuff like that. We'll do some clinical testing to kind of verify if it's more of a joint problem versus more of a muscular problem. Muscle tendon is really sometimes difficult to determine there because they're both connective tissue. The fibers slide over one another. But sometimes you can tell if it's more of a joint problem versus a muscle tendon connective tissue problem. And we do some tests to determine that. Obviously, you go get an MRI and x-rays and things like that, but sometimes those aren't always necessary. We can do those clinically as well.
So if it is a muscle issue, generally how long, I guess there is no generally, but I'm looking for kind of a number, 4 to 6 weeks, 6 to 8 weeks, 3 months. How long does it take for those muscles to repair? I guess it depends on the severity of the tear and a lot of factors like that, right?
Absolutely. It depends individually and everything else. But if you, on the rough overlay and stuff like that, a general would be 6 to 8 weeks. Yeah.
Do you still recommend doing like the exercises and stretches during that period or just laying low and not doing much?
You do what you can, typically. Okay. So, I mean, there's other things that you should be doing as well, but 6 to 8 weeks, if it's a mild strain, typically you should heal over the course of that time and not being totally inactive during that time, but you want to be able to, do the right stretches, and I should probably be icing it to control for any swelling or inflammation or pain. If you take anything over the counter or not over the counter, that's totally up to you and between you and your physician. But then there should be strengthening exercises, like I said, stretching exercises, and other modifications that may need to happen. But typically over 6 to 8 weeks, it should do pretty good. And you should be, I don't want to say good as new, but it should definitely heal if it's just more of a mild muscle strain.
What about a tear? When you say you said this earlier that.
So you can describe muscle injuries or tendon injuries as strains, and strains would be grade 1 would be a mild stretch, very mild, maybe mild tear. A grade 2 is where you're going now, maybe up to close to 50% that you've strained that muscle. So it's a grade 2 strain or grade 2 tear. Now you've gone up to maybe tore 50% or close to 50% of your muscle fibers. And then a grade 3 would be, it's not always a complete tear. It can be a complete tear or anything anything over 50% tearing, they grade it as a grade 3, and they would probably say you would need surgery for that.
So the ones that are grade 1 and 2 just repair on their own?
Ones easily repair on their own typically. 2s may partially repair, may partially not repair, depending on what you're doing. If you're doing the right stuff, if you keep irritating it and you're not in the right posture and you're not allowing those muscles to basically heal like they're supposed to, they might not. They may just form a lot of scar tissue, a lot of bad tissue, and that can cause problems down the line too. But typically if done correctly, and also depends on genetically, there's some genetic component too. Some people heal really, really well, but some people form scar tissue pretty quick and pretty easy. And sometimes those that tear will form scar tissue quicker than they form the muscle or tendon tissue, and that's not always a good thing. So, and you don't know that until an MRI is taken at the very end, or they go in and do surgery, like, wow, this just filled with scar tissue, and then they find out genetically that's something that they have, a genetic trait that's passed on from generations to generations.
So if there's scar tissue, if it's not severe, can that be manipulated to break up where good tissue can regenerate?
Yes.
Okay.
Yeah, there are some techniques that work on that can, depending on the amount of scar tissue or fibrosis, they call it, in that muscle and or tendon, can be broken down and then regenerated into new, quote unquote, new tissue and to heal. But there's you can't say that the entire thing will be, if you have, say, a whole, divot of a muscle, that's going to all break up or break down and rebuild that to all new tendon or muscle tissue. Maybe 50% of it, maybe 25%, who knows? And it all depends, once again, genetically, but there are techniques out there that can help facilitate that. You restart the healing cascade, and basically it's more of a holistic approach, and you can help build up that new tissue.
What's the difference then between the two tissues, scar tissue versus this new tissue that comes in?
So tendon and muscle tissue is a connective tissue, and they slide and glide and contract over one another.
Okay.
They're more dynamic. Scar tissue is basically just like a scab.
Okay. Okay.
Bristle. It just fills in and just locks in.
Okay.
This is your muscle fiber of, say, your hamstring, and
Okay.
slides and glides. But you tear the fibers in just a part of your hamstring, not the entire hamstring.
Mm-hmm.
You're just tearing these fibers here. All right. And they get filled up with scar tissue. Now they can't slide and glide. They can't stretch out. They can't contract. So they can't produce force and help. You'll be weaker because of it. And you also can't stretch out. But these guys are sliding and gliding as much as they possibly can to compensate for that. But they're going to get overstrained, and these are going to get basically fatigued or atrophied the more that they're not used. So over the course of time, you set up a nice bad scenario in that region, that a portion of your hamstring or whatever muscle you're talking about could be your shoulder, your biceps, and your muscles. That could happen too. So those are the things that we need to pay attention to. Like I said, so instead of putting it from the back burner or taking it from the back burner and bringing it out front and addressing it sooner rather than later is optimal. All right. Great questions. So like I said before, there's lots of different activities that you guys had mentioned. So reaching behind the back, reaching in the cabinets, sleeping, all these different things. So different activities will cause pain for different people. And there's no right or wrong. There's no this or that. And you can't always associate one or the other. Like I said, it's the most mobile joint in the body. But more importantly is that everybody has their own independent problem, and one can affect another so easily. So somebody's reaching up may be fine, but somebody's reaching back bothers them, but it may hurt in the same spot. Okay. And it's just, there's no always a rhyme or reason for it. But the thing is you always heard, you want to make sure you're comparing apples to apples and not apples to oranges and things like that. So we never want to compare ourselves to anybody else for that fact, because you don't know what's going on, but multiple things can bother. So as we're looking towards yard cleanup coming up because it's fall, or raking or anything like that, or in the spring planting season, or shoveling over the winter, God forbid that we have to start shoveling snow already, or anything like that may put the strain on our shoulders. So we just want to make sure that, okay, like I said, again, I need to pay attention to it and realize, okay, I need to listen to what my body's telling me. All right.
So Joe, are there like specific pain points that would indicate the type of injury, right? So some are mentioning a pain point in tight, others mentioning up here. I'm sure the pain points are clues, are they not, to what's going on?
Yes. So for us, therapy wise and as medical wise, yes, they definitely can be because there's general patterns, but that's according to textbook. And there's clinical expertise in a number of years as well too, but there's definitely patterns and generalities that we look for and listen to and stuff like that. And that's why we always continue ask questions, because the more you tell us, the more data we take in, and then we collaborate that together. Like, oh, that makes sense. This, and this that you told me falls in line with what I found during my testing. And then here's what we're dealing with. And we can start to tie those dots, connect those dots together. Oh, okay. That makes sense. And everything else. So like, definitely. So they can be for sure, but they can be obscure. You can think about, well, typically if you have a rotator cuff tear, you're not going to hurt right there. And why are you hurting there? I don't know. But I do know that I found this, I found that, and we're going to work on that stuff and see if that starts to help it. And then lo and behold, like, oh, maybe a session or two into it, we find something else that we didn't find during the evaluation. And all of a sudden, that's why you hurt there, because we didn't notice this or didn't find that out. And so we can start once again. It's kind of like a little bit of a treasure chest, little roadmap. So we just kind of delve into it and we start to dig a little deeper, start to loosen some things up, strengthen a few different things, try to mobilize something like, okay, this all now. And then you have a little bit of a breakthrough, like, okay, here we go. Now we can explain this a little bit more. Or all of a sudden, like, oh, that little whatever feels a lot better. And it may not have had anything to do with it. It may have been just a total compensation that you made because of something else. So, you know, I wish I could tell you for sure on that one, Bruce, but yeah, definitely those where you have pain and doing different things can lead us to other questions. And then we can get to a whole bunch of more specifics, hopefully. One of the biggest things, as the sheet talks about, is that, you know, people ignore it. That's the worst thing that people can do. The biggest mistake that people can do is ignore it. The second most biggest thing that people do is they'll mask it or alter it by taking medications or injections or over-the-counter inflammation. Even ice and using ice or heat, even though it's good for you at times, can also just mask things, and you're basically not addressing it. And that's the number 3 point, is that we want people to address their issues and be proactive on those. So that's what we kind of try to do in physical therapy, is really empower our clients, educate our clients, and really become proactive. So, all right. So we're going to talk about the most.
Joe, when is when is heat versus cold recommended?
All right. So heat and cold, it's a great question. I get it asked all the time. They bombard the nervous system with extreme temperature changes. So if you want to think about your pain fibers as Roosevelt Road and your temperature fibers as I-88, Interstate 88 Expressway. So you put that heat or cold on the body, and all of a sudden now Interstate 88 is just flying. All right. And so those temperature fibers go to the brain really quickly and back, and all you feel is heat or cold. Well, the pain fibers are taking Roosevelt Road and hitting every stoplight, and they're a lot slower. So they get left out. They get blocked. So you don't feel the pain anymore. You feel the heat or the cold. You take that off, okay, and then all of a sudden the pain may come back.
So that's why you're saying it just masks it?
It just masks.
It doesn't really go away. It just goes away while you have the heat or the cold, because you're not thinking of the pain.
Exactly. You're not aware of it because it's being blocked. So that's the blocking mechanism. But there is therapeutic. So if you truly have swelling in the area, some inflammation, swelling, ice constricts the blood vessels and will help pump that swelling out of it. Okay. Heat, on the other hand, typically loosens things up. It actually opens the blood vessels and will bring more blood flow to the area. So if you're more stiff and just sore and feeling tight, that's why heat feels really good, because it opens up the blood vessels, brings more blood flow there, and now I'm loose and lubricated a little bit easier. But if you already have swelling in the area, and I put heat on it, and it's painful, okay, I just feel that heat. Oh, that feels really, really good. But now I've just brought more blood flow to the area. I may increase the swelling. So once the heat goes away, and after 5-10 minutes after the heat's gone away, all of a sudden that body part is throbbing, boom, boom, and it hurts more than it did before, and throb and aches even more. Probably because now you just put heat on it and you just brought more swelling to the area. So then the ice becomes therapeutic at that nature. So yes, it masks, but it can be therapeutic. Okay. But it won't heal anything. It just becomes therapeutic to help take the swelling away. And that's why there's the RICE principle: rest, ice, compression, elevation. If you use RICE as your acronym, R is rest, I is ice, C is compression. So wrapping it up, and then with an ACE bandage very lightly or something, and then E is elevation. So you're wanting your arm, leg, whatever, above the heart, so that swelling can come back down into your lymph nodes here, or if your leg, into your lymph nodes, into your groin region, to help reprocess that swelling. So, hope that answers your question. Mm-hmm. Awesome. All right. So Roman numeral 5, the most common causes of shoulder pain there. A is there's a problem in the joint, and that's typically arthritis. All right, so that's a wearing down of the joint. So abnormal wear and tear of the ball and socket. So what'll happen a great deal is that all those tight muscles now will pull that ball up into that socket. All right, there should be space there, but it gets pulled up in there, and then now you're rubbing and grinding. So the smooth surfaces start to rub and grind, and that will create some arthritic type changes, some degeneration in there. So that's the ball and socket or joint problems that you can occur in the shoulder. There can be a tear or a strain in the muscles or tendons of the rotator cuff or their biceps or other muscles around the shoulder region, and that can cause problems as well too, and that can be painful. There can be what we call an impingement, all right? And so that impingement, I'm going to bring the model back out here. So as we see the rotator cuff muscles, and there's the back part of your collarbone here coming in, and then the back part of your shoulder blade, and there's a dome there. So those rotator cuff muscles go underneath that dome. Well, if you can imagine that ball now being sucked up in that socket, all right, you're now compressing those rotator cuff muscles potentially in that ridge or that dome right there. So you impinge that tendon, you compress that tendon, and even the bicep tendon gets compressed in there too. So an impingement syndrome typically is where the rotator cuff tendon and or bicep tendon, or all of them, one or more, depending on how much of an impingement there is, will basically get compressed. So as you are elevating that arm up there, I'm jamming that up in there if it's not moving like it's supposed to. So you'll get an impingement syndrome. Or if you see, and one of the big things is, another one is posture, and a lot of these things are related. If I'm really, really rounded and I have my shoulder hiked up because it hurts, and I've been in this position for so long because I did something to it, but I just didn't really want to take care of it right away. So whatever the reasons is, and now it's been months and I've been like this, and now I can't do it. But every time I raise an arm, I'm shrugging up and doing this. I just keep jamming. And so you might have actually tore a muscle in there originally, but now I'm impinging and compressing it and have a rotator cuff type syndrome in there, and I may be hurting something else as well. So there's a whole bunch of stuff that one kind of injury can lead to another. Now I'm wearing things down even more, and so I'm degenerating that joint even more. So I may have some arthritis, I may have a tear, and I may have impingement syndrome. I may have all three kind of going on at the same time. What came first, the chicken or the egg? Sometimes you don't know, and sometimes we have to just kind of start to work and address them, which one we feel that we can address and have success with first, and then move on to the next one, and then move on to the next one. And then poor strength and stabilization. Sometimes it's just a matter of just being weak. You start a new job, you're doing something with your arms now, you've changed from a desk position, and all of a sudden now you're working at the UPS store, and you're taking packages and you're moving packages all the way around all the time, and all of a sudden your shoulders are bothering you. And it might just be because for 20 years you're working behind a desk and not really strengthening, not doing much physical work, and now all of a sudden you're doing this 5,000 times a day, picking things up, moving things over, and all of a sudden your shoulder and everything's hurting. It's just because you're weak. Nothing else, but just because you're weak.
So the pain would go away once you start strengthening it?
That would be the hope and goal if it's an isolated strength. And if you start doing it right away, Mary, if you don't ignore it for 6 months, if you start strengthening and seeing somebody and doing some strength exercise right away, oh, that's much better. And then nothing else gets hurt in the process. But if you wait, you can have other problems. But yeah, it can be something quite so simple. And it can be just a straight postural mechanical. It could be something where, and we see this a lot with younger people, older people too, but that becomes more fixed. But we see a lot of younger people, they'll just come in, backpack syndrome, computers, phones, the whole 9 yards. They're like this, and they just can't, and they're hurting and stuff like that. And we just get them to be where they're supposed to be. And all of a sudden like, oh, wow, I can lift that arm up now without pain. And I'm not having that pain when I'm typing and everything else and work on the computer. All right. So it's just a postural mechanical problem. Just get them in the right alignment, and they're young enough, and they're, they can adapt a little bit easier and everything else. It's a little more lengthy when it's somebody that's been in a bad position for 20 years because they've been working at the desk for 20 years, a computer for 20 years, where they've got forward head, forward shoulder, like this is normal for them. And then that's upright. This is where they want to be, and that is totally upright when they're supposed to be here, and that they can't get there at that point in time. So now they're kind of getting fixed. So we have to really work on immobilizing their spine and mobilizing their shoulder joint and everything else, and then stretching everything else out to get them in that upright position, or get them as close as we can to that upright position. So it can happen. It just may take a lot longer with somebody that's 45 versus somebody that's 20 or 25.
Or 65.
Or 65. Or even 85. It doesn't matter. So, yeah. All right. So successful therapy, number 6 there, we talk about, we do a lot of hands-on therapy here in the clinic. Manual therapy, we find that works really well. We do a lot of stretching and strengthening exercises for our clients here in the clinic. We isolate stretching exercises and strengthening exercises that they can't do at home here, and then we have them do strengthening and stretching exercises on a daily basis at home. So we do things in collaboration. We do a couple different treatments that I think I put on there, and one of them was ASTEM, augmented soft tissue mobilization, and that's, Chris, what you'd asked about, the breaking down the scar tissue, that helps break down scar tissue. Okay. Another one I think I put on there was TMR, total motion release. It's kind of a different theory out there, and so we do something where, like I said, it's another tool in our toolbox. And most recently, which I didn't put on there, Julie, our clinical director, is now certified into doing functional dry needling. So getting into trigger points within the muscles and tendons, and really just trying to isolate and getting them to break up and loosen by doing some functional dry needling. It's found to be really, really successful.
Yep, and I can attest to that one.
There you go.
For a hip. Yeah.
And it can work really well with the shoulder muscles, for sure.
You say functional dry needling. Is that kind of like acupuncture on that kind of order?
On that kind of order, yes. And since I'm not certified, I can't tell you exactly the difference, Chris.
Okay.
I can have Julie give you a call and talk to you a little bit more about this. So I don't want to misspeak on anything.
Okay, thank you. When you said trigger points, I'm like, fibro, yes, the trigger points would be really good. Yeah. Okay. Thanks, Joe.
You're welcome. And then something we didn't really even talk about, up at number 5, is we looking at the neck. Okay. I had you move your neck. So the neck, the nerves and blood vessels and stuff like that supply the arm are coming from the neck. And if there's something wrong up here, you can have stuff going on down here. So there's a whole other area. So when we're looking at the shoulder, we have to look at the neck. So there might be something that's going on, and it can not just isolate your shoulder at all. Elbow as well. So we look at above and below the joint, and even the wrist, but elbow and neck are always looked at. So the big things is we just need to determine the root cause of your problem. So that's why we ask a lot of questions. We do a lot of special tests. We collect a lot of data, and we try to formulate it and really find out what's going on with you and what your problem is. So like I said, that's why we ask a ton of questions, and we do a lot of special tests, and we're kind of reassessing each session to find out what's going on. What are we making progress towards what's going on in your injury? So
if your symptoms are similar to what you stated or last 5 minutes or so, that's got to be much longer than a 6 to 8 week recovery, because you're looking all through your possible neck and all through, your lower back, right? So, what's the longest you've treated somebody?
What's the longest we treat somebody?
Yeah, because I just don't think like 6. I'm just trying to understand, if there's a tear or something you rested, I would believe, maybe you recovered. If you had bad posture for many years, and you got problems with your back and your shoulder and your neck, that's got to be, I would think, a longer recovery period.
So yeah, obviously the more issues you have, sometimes it can be longer, but then the other aspect to that, Scott, is that if there's multiple factors, which I have a lot of times, people come in with their shoulder, especially because it's the most mobile joint, there's lots of stuff going on, and people think, geez, Joe, I'm a mess. It sounds and seems like it, but the thing is, everything we talked about, we can address. We can work on the tight muscles. We can work on the weak muscles. We can work on teaching muscles how to fire. You can work on your posture. You can work on all these different things. And so there's so many different aspects that you can work on that, okay, it may take a little time, but you should just start to see gradual progression and improvement. So for therapy wise goes, our average length of treatment here is anywhere twice a week for maybe, 6 weeks on the average, maybe 8 weeks, maybe 4 weeks, but somewhere around that time frame, give or take. Like I said, we're having clients work on things on their own at home during that time frame as well. And then you may be, unfortunately, you won't be 100%. Insurance won't let us get you to 100% before you get to be discharged from therapy anymore. It used to be about 20 years ago, we could take people up to 100%. We can't do that anymore. They won't let us. So wherever you're at by the time you're done, and how you grade yourself at that end of that, say 6 or 8 weeks, that I'm 70% better, 80% better, 90% better, wherever, how my percentage I'm better. And then you're working on that program on your own at home after that for X number of weeks on a day-to-day basis to get to where you want to be. And then, which may be another month, maybe another 2 weeks, maybe 6 weeks, maybe it's 2 months, whatever. And then you're going into a maintenance type program where, okay, I can work on these things and pick and choose and kind of thing, and work on a maintenance program so I can maintain this new level of mobility and function where I'm at, where I want to be. I know I have to continue that. And we will always keep in contact with our clients to make sure that they get to that maintenance portion of it. So I hope that answers your question, Scott.
Yeah, it did.
Okay. And as far as time-wise here in the clinic, the length of sessions typically are roughly an hour long, 45 minutes on the short end to an hour and 15 minutes on the long end, but typically about an hour. Clients are here typically for about an hour. We see our clients for 30 minutes of one-on-one time, and then they're here for anywhere from 15 minutes to 30 minutes to doing exercises after that. So, but all great questions. So I hope, and we can talk more afterwards too. Just one of the big things is the next section is that a super important point is that everybody's basically problems are going to look differently. And so when you go to therapy and stuff like that, making sure that finding that root cause of the problem is the important part of it. So if you go somewhere and they're addressing your shoulder pain as being a muscle strain, but it's more arthritic in nature, there's really not any muscle strain in it, or if they're treating it for arthritis and it's a muscle strain, or if it's an impingement problem, or it's truly mechanical, or whatever it may be, and they're not addressing all the different issues that might be going on with you, you're going to have limited success. And so you just really want to think about, as you're going into getting this, taking this, or getting your shoulder taken care of, I should say, is that you want all things to be looked at globally and not just one portion of it. Because that will limit your success percentage and everything else like that. So you just want to think about that when you're moving forward with your health and taking care of whatever body part, whether it be a neck or shoulder, hip, or it doesn't matter what body part, is you just want to make sure that you're getting down to the root cause, whoever's working with you. And it may be a team of people, maybe one person, whatever it may be. You just really want to think about that, because if you do the wrong stuff, it can be very uncomfortable, and you can go, and you may have heard people say, well, I went to therapy for my shoulder and all it did is hurt me. Everything I did was hurt. And so I stopped going to therapy. Therapy is a bunch of hooey. And if they were doing the wrong thing for the wrong problem, I can see that. And not just for the shoulder, it could happen for the hip, it could happen for the back, whatever. And so you really have to, hopefully pay attention to that. And like I said, they're really looking at trying to get to the root cause of it. So, and they can address all those issues. And they're always.
Do you usually take x-rays or MRIs before you start a treatment, or do you just go through a whole series of questions and like feeling the areas and things?
It's a great question, Mary. So we don't prescribe anything. As in our physical therapy practice, we don't prescribe anything. And so x-rays and MRIs, if we feel that x-rays and MRIs would be necessary, we would have you go to your physician and recommend to get those, whatever appropriate radiographs that we need, MRI, x-ray, CT scan, whatever it may be. So that's definitely possible. Typically we don't, because we will do a comprehensive question, special tests, palpation, muscle testing, different range of motion testing and stuff like that. And that gives us our clinical information. And we should get a pretty good picture of what's going on there. And after a week, 2 weeks, 3 weeks, if we're not gaining any momentum here and not really doing much and things are, then we may stop. You know, hopefully before that we've even stopped and tried a different route. Like, okay, we tried this for a few sessions and we're really not getting anywhere. So we're gonna go a different avenue. And we've done that 2 times, maybe 3 times, like, you know, maybe we need to get you back to the doctor and get a picture of that. So we're always keeping in contact with the physician that way. So we send you back and get some more radiographs or some other further testing. So maybe it's an EMG, maybe it's an X-ray, whatever it may be.
Okay.
All right. All right, before we cover the exercises that are there, any other questions?
Yeah, so typically if it is a tear or an injury to the muscle, are there more likely muscles to be torn than others? In other words, are there more common spots where you go, oh yeah, that's one of these, and you know, that you identify them more quickly?
Yeah, so there are some more typical ones. So the most common one is going to be the supraspinatus, and that's this top muscle. I'm going to bring out this guy here again. So of our shoulder here, and if I flip him up, so you're looking at the top, looking at this muscle here, that's supraspinatus, and that's the one that comes out right there on my finger underneath. So that's the one that typically gets jammed up underneath that ridge more often than not. But it also depends on where that happens. So you have throwers, and it may be actually the other one in the back here, this infraspinatus might get torn more because they jam it more back in this position, and they're jamming it and cramming it there, and they may hurt it more in that position versus the general layperson like ourselves, where we're always jamming it like this and just piston it up into there. Kind of
so when you had us do the exercise and we brought our hand behind our back, tried to, you know, like if you try to touch hands like that, if that causes the most pain for me, if that's the case, what would be the most likely source? Do you understand what I'm asking?
Yeah, oh, I do, and I can't honestly tell you exactly, because I don't have my hands on you and doing other tests and stuff like that. But when you have limited range of motion going to your back, so there's either joint restriction here, ball and socket is restricted joint wise, or you are in a position where you're already locked up, and that might be more muscular to cause you to lock up in here. And now I can't extend back because I'm so tight in front. I can't extend back, and I can't turn and rotate in anymore going behind. So it could be just a muscular issue too that needs to get released, and all of a sudden now, instead of that ball being forward, up, and in, and I can't rotate anymore in to get back there. I can't go back anymore because I'm just locked up. I get that ball down and back, and now I've got space. Oh, look at that. Now I can rotate in and go back, and I can get my hand back there. So it might be a joint thing. It might be a muscle thing. It could be both. So, you know, until we get a set of hands and do some other special testing, they couldn't tell you. The typical thing is if you try to use that muscle, so if you're trying to lift something up, whether it be just your arm with no weight, or you're trying to rotate it out, and you're activating the muscle. And if you activate the muscle and it's painful, typically that might tell you that there might be a little bit of a muscle strain, but it doesn't always mean that. It could just mean, once again, it could be mechanical because you could be in a bad position, you're trying to rotate it out, and you're just grinding and pinching, and it hurts. But if you are truly in a good position and we have you activate that muscle and that hurts, there might be a muscle strain there at some point, a mild strain and stuff like that. If you can't do it at all, like you just physically can't do it, and there's no movement, that's probably a complete tear. So if you fully can't move your muscle, you can't move it in one direction, and there's no pain with it, you probably have torn the muscle at that point in time. So the pain fibers are gone, and the muscle is just not attached. Or
typically that would be. I'm sorry. Go ahead.
No, yeah, that's it.
No, so it sounds like that there would be like an incident or something that could cause the trauma, right? Or if you're working out too hard and you just strained it, you just went further than you should have gone. That kind of thing. I mean, that's what I'm anticipating. how I've done it. I mean, because I really don't even know how.
So typically, yeah,
You know?
typically we look for a mechanism of injury, but with the shoulder, because it's the most mobile joint in the body, like I said, I would say probably at least 50 to 60% of the time I have clients come in, they don't know. It's
Really?
built up, and it's kind of like the last straw that broke the camel's back, and don't know really always what it was, and it's all of a sudden, man, it just started hurting, and didn't do anything different. I didn't rake leaves, I didn't clean out the crawl space, I didn't do anything.
Yeah.
And then, once again, you start getting into therapy, and you start to ask some more questions, and you kind of figure out, oh, I did change jobs 2 months ago, or I did this and something else, and you start to kind of can lead back to it and work our way back to it. And I'm not saying that it's always the case, but like, that's a plausible hypothesis then. Maybe not. Don't really know.
That makes sense.
All right. So really quickly, those stretching exercises in the doorway, as Mary said, so there's 2 exercises in the doorway. So I'm going to bring you over to doorway. All right. So you see our doorway there. Hopefully you guys can see me do this. So as the picture said, you do it with the arms down at our side. And leaning forward.
You're stepping 1 foot forward.
Yep. So you're in the doorway with one hand on either side of the door jamb. You're in good upright position, not looking down. And it doesn't matter which leg you step, you just step forward with one leg. Doesn't matter. And you don't have to go very far. And you just step forward with one leg, deep breathing, relaxing, holding that, and you're just trying to get that muscle to elongate and stretch out. We do it with the arms down low first, 20 to 30 seconds, 3 times. And then we go with the arms up a little higher. I'm going to bring this up just a little bit. So then we try to bring it up a little higher, somewhere about shoulder height, maybe chest height. You can have your arms out a little wider, whatever's comfortable to you. And the same thing is you take a small step forward, staying in your good posture.
That one feels great.
I
To
was
me,
going to
at
say the
least.
same thing. It feels so good.
Yeah. It did feel really good.
And yeah, I mean, and you just find out what comfort level you are at,
Yeah.
where those hands are at. Obviously try to have greasy hands so you're not dirtying up the walls, stuff like that. Don't eat pizza before you do it or anything, but yeah, just put your arms out, nice and easy, wherever's comfortable down. We start low, we get a little bit more of the bicep and the front part of the shoulder, more in the mid-range, we start getting into that pec. And then once those start feeling good, then we go, which I didn't give you the picture of because I don't want you to do it right away. And then you get your arms up in the doorway, up a little higher. Now you're gonna get the pec a little bit more into this region. So we work all 3 different angles. Eventually we start down low, and here we start low and mid. And then once you feel a little better, can I get up in the doorway? Same thing, keep the head in good position. All right. Do those throughout the day. Mary, if you're home working, 3-4 times a day, especially before you go to bed and stuff like that. So it's a great one to do before you go to bed so you wake up a little bit looser.
Yeah.
And same thing for Scott and Bruce, and especially Scott, you talked about waking up with that. So trying to do these stretches beforehand, before you go to bed, and hopefully then you wake up feeling a little bit better, and maybe a little bit looser too. So that might help out. The other is the shoulder blade retractions or scapular retractions, and basically it's just squeezing your shoulder blades together.
Feels good too. I like that one.
Just gently pulling them back,
Yeah, that feels good.
and you want to keep your head in a good upright position, nice and easy. And you can just do these 10 at a time, 15 at a time. Once again, sitting, standing, doesn't really matter, but you really want to just think about, can I do those, and just start activating those muscles. And while you're thinking about it, we can just think about posture. We want to really think about ear holes, mid of our shoulder, mid of our trunk, and our hips. So we want to just be, instead of being in this position, which most of us are at typically, and you'll find me at the end of the day, this is where I'm at as well. But you want to think about being in a more upright position, and can I align my ear holes with the mid of my shoulders, with the mid of my trunk, And that part of that is, can I gently squeeze those shoulders? You don't have to pull back hard like Forrest Gump. That's not what you're looking for, but just nice and easy. Can I gently squeeze those shoulders to get in a little better upright posture? Can I sit up a little bit more? Can you think about if you were like Pinocchio, someone's pulling a strand of your hair, can I just pull myself up, lifting your collarbones up to the ceiling? Whatever visual or wording that helps you think about that posture a little bit more. So I tell my clients all the time, every 20 or 30 minutes to set that alarm to go off, and then you do a posture check. So
Yep.
set an alarm on the phone, on your computer, whatever it may be, posture, alarm goes off and you do a posture check. So that help ease some pressure on the shoulders, on the neck as well. So you can do a posture check, you work on shoulder blade squeezing, and then the doorway stretches. So those are some easy things to start with. We start all our shoulder clients off with those exercises day one, and then we progress from there. So we're going to get to really quickly before we have to leave here, because we're on the hour already. I want to show you your sleeping, Scott, or Bruce, you said sleeping. So we want to make sure sleeping wise here. So I hope you guys can see me here. All right. So there's various options for sleeping. So the biggest thing is you want to keep your head in this first position. You want to keep it here. You don't want to have too small of a pillow. If I'm sleeping on my left side, I don't want to have too small of a pillow. My head's cocked down. I don't want to have 2 or 3 pillows and too much. My head's cocked up. So you want to try to keep that good head alignment here. That's the first part of it. The next part of it is when you're on your side is, is your bed hard? Is it firm, too firm, or is it too soft? Are you squishing into it? And am I pushing my shoulder forward and compressing it? Or am I rolling back too far on it? So thinking about that position. And then what is my top arm doing as well? Because what will happen a great deal when we sleep is we'll have too little of a pillow, and we'll have too much of a pillow, and then we curl up in our fetal position.
Mhm.
So we're rounding in here all night long.
Mhm.
And then when we wake up, it's just irritating. So if you've got some especially arthritic changes more than anything, is that you're just compressing that ball and socket even more. And now that really, really hurts when you wake up, you've been on it too long. Oh, it hurts when I wake up, and now I'm rolling over. And it just doesn't feel so good. And even if I lay on my opposite side, if I'm in that, my arm drops down and I'm in that fetal position, it may hurt because I'm still compressing it. So there's some things you can do. So, like I said, first and foremost, is you just want to make sure your pillow, and you keep your head in a nice level position. What you do with your bottom arm doesn't really matter. You just don't want to make sure, like I said, is it too far out in front of you? That might be problematic. Is it too far directly underneath you? And you just got to find that sweet spot. Now, there is a caveat. What we do when we sleep, we don't control. So you may start in a great position, but it may not last. So you just have to realize that. So you're in this position. All right, so my head is in good alignment. I'm okay with my shoulder. But now, what do I do with this? Because I'm collapsing.
Uh-huh.
So you take another pillow, and then now maybe I put that top pillow here and block. Or as you said, Scott, if I find that sweet spot, sometimes it's hooking your thumb. If you're wearing a pair of shorts that you have a pocket or somewhere you can hook your thumb, or you just kind of hold and right behind your rear end almost. Once again, it doesn't stay there.
Uh-huh.
Too far back, like you said, it's going to hurt because it's going to pull you back. So you just have to be careful. But that sometimes can help by using a pillow. So you can do what you want to normally do, but it kind of blocks you and doesn't let you come forward as much. Now, if you are on too firm of a surface and it hurts just to lie on it, the other thing you can do is you can put another pillow, fold it up maybe, or blanket, and you can actually prop yourself up in that midsection, and so you're not putting as much pressure on that down shoulder. So you have to play with the amount of thickness that you would sleep on here. You still may need a pillow up top, you may not. What I'll do sometimes to start sleeping for me is I'll put my arm So I'll rest my palm on my bicep here, and I'll start in this position. Sometimes I'll start in this position, whatever. So I try not to do this too much, but I'll wake up like that as well. But you can unload that shoulder by sleeping here. It's not easy to always get used to, but it does give you options to try as far as positional relief, especially if lying on your back is not something that you want to do or typically do.
So I've,
Lying on,
oh, go ahead.
Go ahead,
go
Mary.
ahead, Mary.
I was going to say, I've actually gotten used to sleeping without a pillow, but towards the beginning when I started doing that, I felt like lower back pain. And then I started putting one of those roller pillows underneath my knees, and that helped a lot. But
Mhm.
do you recommend sleeping without a pillow, or?
It's all comfort level back there and then how hard the surface is or how soft the surface is. And some people will just even use, towel rolls. They'll lay on their back and they just have a towel roll underneath their neck, and that's enough for them. Or they'll put that towel roll. They really don't have anything up there either. They'll just put that towel roll underneath their neck. I'm one that just to make sure that you have, if you're a broad shouldered person, you're going to need some pillow. You can't not have a pillow if you're on your side, because otherwise you're just going to tilt down. So you kind of have to have a pillow if you're going to lay on your side. And sometimes in your back, you may not have to. So it depends on how thick you are too, thick chest and thick shoulder and stuff like that. So, anatomically, sometimes that determines whether you need a pillow or should have a pillow. So I just don't want people to have too much or too little, because that can also put pressure on their neck and shoulders also.
Mm-hmm.
Does that
It's
help
the
you out a
back
little
of
bit,
the-
Bruce, you think?
What's that?
Does that help you out as far as some suggestions sleeping wise?
Yeah, it does. Thank you. I'll try one of them tonight.
Absolutely. What were you going to say, Brenda?
Well, I was just gonna say, if we're on our backs, is that the easiest way to have our shoulders just be relaxed because they're just sort of there?
They can be, but most of the time if I have people lying their back, they're going to find out that because there's such tightness in their chest areas, their shoulders don't even hit the back of the beds
Oh,
because they're so
okay.
tight there. Like, oh wow, back of my shoulders aren't touching my bed. So because they're so tight. Or the other thing is if you are sleeping in a very soft bed, or one has a really, really soft pillow top maybe on it, it's like a bad chair, like a bad recliner or a bad car seat that has bucket seats that all they do is push you forward like that. So sometimes laying on your back just pushes you forward, and that compresses even more. And if you've ever woken up with the numbness and tingling in your hands or arms, sometimes it's because of that, because what we're doing is we're compressing the blood vessels and nerves. And I think that that's probably a little bit what you're experiencing, Mary, is the blood vessels and nerves are coming from that neck underneath the collarbone on top of our first rib going out the shoulder can get compressed. And that's my guess what's going on with you. Don't know, obviously, until you would be seen and stuff like that. But that's my guess. And that's what will happen a great deal is if you're on your shoulder and you wake up like, oh, my arm fell asleep. If that's ever happens because typically we're compressing the blood vessels and nerves in this space we call it the thoracic outlet because of how we're sleeping. So making sure you do those stretches before you go to bed is always good, because if you've been tight and doing stuff all day long and you go to sleep like that, it's really tough. So making sure you stretch out.
So totally off the shoulder, because you've had me thinking most of the night. If the shoulder is the second most, is the knee the first?
Back.
Or the back? Okay. It was bugging me.
Always a good question.
Inquiring minds.
I'm telling you.
All right. What other questions do we have to finish up here? Anything else that didn't get answered? Like I said, I'll stick around afterwards, so to answer any other specific questions too that you may have. So
I'm done. I'm going to see Julie tomorrow.
great.
Just thumbs up for Joe and for those that maybe
Yeah.
have never used him. I've been there, and this may sound bad, I've been there for years. When you were asking how long, I was like, I don't know, but I have different parts each time I go, so it's not as bad as it sounds. Bye, Joe.
Bye, Brenda.
Hi, Brenda. I'll second what Brenda said. I haven't been there for years, but Joe and his team are phenomenal. Really, really good.
Thank you.
And you do a great service for us. Thank you for the aids. Appreciate that a lot. So
You're welcome.
I'm going to give one suggestion on the side sleeping that I have found that helps, and then I'm signing off. I don't have the pillow propped up here. I have a nice pillow that I just rest my other arm on so that I'm not reaching all the way over, but I've got it kind of propped up. That's helped me some.
Yeah, and it's whatever works exactly.
Yeah.
Your imagination is your limitation.
You don't want to go into mine. It's sick. Okay, so y'all have a good night. Thanks, Joe.
Bye, Chris.
Bye.
Bye.
So any other questions? Like I said, if not, and I can stay, like I said, afterwards, but definitely for you, Mary, Scott, and Bruce and stuff like that, for taking the time and stuff. What we do for all of our people who take the time to spend with us during the workshops and everything like that, we offer a free screen, so no strings attached kind of thing. So 30 minutes, you want to come in and see one of our staff therapists, our clinical director, Julie, Shay, myself, whoever, and find out a little bit more about what's going on with your shoulder and see if therapy would be beneficial or not, or what's the next best step. Ask more questions. You definitely do that and take advantage of that if you want to. So we're here for the community, and we just want people to be educated and to make the right decision and have the right information to make the best decision they can for their health. So just want to offer
Is
that.
the 30-minute evaluation, do you think that's usually enough to determine what sort of problem you're having or what's causing the issue?
Yeah, for our screen, we it's not a full-blown evaluation. We do a kind of a nitty-gritty, and it's enough time to find out and have a really good indication of what's going on with your shoulder and or whatever body part, and whether therapy would be beneficial or not, and give a game plan of what we feel we would want to do with our clients. An evaluation then is just some extra stuff, collecting more data just to solidify that.
Okay.
An
Well,
evaluation
I definitely appreciate the stretching exercises. I've gotten into the classical stretch, the eccentric stretches, which feel really good too. Like I said, I think in my case, I just need to stretch more. I mean, I can sit for hours at a time and not even get up. So like I said, I'm definitely going to start those stretches because I saw them on the sheet and they felt really good the first time that I tried them. So
That's great.
Definitely going to try them tonight before I go to bed. So thank you.
Oh, you're
Appreciate
welcome.
this.
You're welcome. And call or email or whatever, have any questions.
Will do. Thank you.
You're welcome.
Good. Yeah. Thank you, Joe. I appreciate the information tonight. Some things to think about. And I've heard a lot of good things about you as well. Tracy's our dear friend, and she's had a lot of really nice things to say about you. So I'm interested, but I just want to take some time to think about it a little bit and then reach out when the time is right.
Absolutely. No worries. We're here for you guys. We're not planning on moving or changing addresses or anything like that. So yeah, if you have any other further questions, don't hesitate to give us a call or give us an email or whatever it is, Bruce.
Awesome. Thank you, Joe. Have a good night.
Yeah.
Take care.
Hey, so Joe, I just have one question about sleeping on my stomach.
Did you say on your
Yeah.
stomach? I'm sorry,
Yeah,
Scott.
I slept on my stomach for my whole life. And then when I
Yeah.
started problems, they told me to stop sleeping on my stomach. And I've gotten not better. So any new news on sleeping on stomach?
That's a tough one. So, all the experts say don't sleep on your stomach, more for your back and your neck versus the shoulder. But, I'm not a stomach sleeper myself just because it's just not me. My wife is a huge stomach sleeper, but, it's just a matter. Is it bothering does it seem to bother more your neck or is it bothering your shoulder, do you think?
I mean, my biggest complaint is my scapula. So I was just curious because I just asked if there was new advice on stomach sleeping or not. Basically, sounds like they still tell you shouldn't do it. Yeah,
for the most part, they tell you not to. But so, what shoulder blade is it that bothers you? Left or right?
Left.
Left. Okay. What side of the head? When you sleep, do you turn your head to the right or turn your head to the left typically?
I normally sleep on my right shoulder. So, whatever that would be, turn my head to the right of it.
So you turn your head to the right. Okay. So do you have your right arm up or your left arm up?
My right.
Right arm up,
Right.
head to the right, but it's your left shoulder blade that bothers you?
Yeah.
Okay.
But I'm gonna have to read your stuff and consider coming. So I'm self-treating myself now. I've been through multiple weeks and usually to no avail. So.
Yeah. So what you're describing is interesting because obviously, going through my head, thinking textbook and stuff like that, not textbook. So, definitely would be something I'd like to, I would say would definitely need to look at a little bit more and discuss a little bit more, and probably in person would be better just to see. So it could at least give you a better idea of, okay, ooh, maybe try this, or, hey, that makes sense, or whatever it is, to give you the best information. I just don't want to start spewing off stuff because I'm not sure, I don't want to just blow.
No problem. Understood. Okay, well, I'll be in touch, Joe. I appreciate it.
You're welcome. Have a great rest of your night.
Yep, you too. Take care.
All right. Bye-bye.
Bye-bye.